Good morning, everyone, or good afternoon for the East Coasters. My name is Tia Oso, and I'm the Senior Communication Strategist with Action Center on Race and the Economy. And we're going to get started in just a few minutes, just giving our attendees time to log on, giving Facebook time to tell all our business, and that we're going live. And then we'll get started in just a minute. Okay, so I'm going to get us started and do some intros and an overview. So again, like I shared, my name is Tia Oso, and I am the Senior Communication Strategist at the Action Center on Race and the Economy. And this is our webinar, or excuse me, digital roundtable, fancy term, called Poison Profits. And we're going to talk about race, public health, and big pharma. We're really excited to have this panel today and this discussion. And following the roundtable, we're going to be releasing our latest report, Poison. And we're really excited both for this discussion and building power and education and sharing analysis around how we can address the really egregious issues that are being caused by Big Pharma, by Wall Street, by our public health policies and drug policy, which we're going to get into in our discussion today, and also talking about what we feel are the solutions and the demands that we need to be pushing forward. So about today, we're going to have this really critical discussion about healthcare, race, and the pharmaceutical industry, and why profit has no place in medicine. And then we're going to also talk about what it is that what are communities experiencing, what is some expert analysis, and then what is it that we can do. Following that, we're going to share the report, and this report is being produced and published by ACRE, the Action Center on Race and the Economy. I'm going to tell you a little bit more about us. ACRE is a campaign hub for organizations that work at the intersection of racial justice and Wall Street accountability. And we provide research and communications, infrastructure, and campaign support to help grassroots organizations that are working on campaigns, or we help them to develop campaigns to win structural change. We think it's really important that we take on racial capitalism and the other root causes that are creating disparities that are targeting our communities for discrimination. And one of those areas is around the pharmaceutical industry and public health. A lot of times we talk about health disparities and health inequity in such a way that Black and Brown communities are, you know, the victims of these things are it's the result of what's happening in our communities and our culture, and not pointing to the structural issues and the ways that we're being targeted, how racism is targeting our health, how policy is targeting our health, how the pharmaceutical industry is targeting our health, which is the subject of our report. I'm going to turn it over now to ACRE's co-executive director, Maurice BP Weeks, to talk a little bit more about that, and then we'll introduce the rest of the panel.
Thanks so much, Tia, and thanks to everyone who joined this roundtable. As Tia said, my name is Maurice BP Weeks. I'm the co-executive director and co-founder here at ACRE, the Action Center on Race and the Economy. And today we're releasing a new report that's titled Poison: How Big Pharma's Price Gouging Kills Black and Brown Folks. Now, that title for some folks might seem pretty shocking. Could pharma really be responsible for the deaths of tens of thousands, if not millions, of Black and Brown folks in this country? And we see how you could think that that's a sensationalized notion, but the fact of the matter is, it is also absolutely true. Our report documents an industry that's so hell-bent on financial profit that they will do anything to maintain their strong corporate power and corporate position. And it certainly isn't just the corporations themselves. Our government is often highly complicit in these schemes, mainly because it has been captured by some of the very same people who lead or have led in the past these pharmaceutical companies. The very model, in fact, that we use to research and produce medicines in this country is highly flawed. And medicines that are often created with public resources, either through the NIH or through funding from other public entities, are then given over to a corporation who gets a legal monopoly on producing and setting the price for that medicine for years. Most people have probably heard the story of insulin exponentially growing in price, even though the formulation hasn't changed. Or maybe you know the story of Martin Shkreli jacking up the price of an AIDS medication. The same is true for several crucial life-saving and life-dependent drugs. This all, of course, takes place in the context currently of the COVID-19 crisis. And while this global pandemic sweeps through our communities, we see it disproportionately impacting Black and Brown people. And the reason for that is really no medical mystery. Our healthcare system, like any other system in American life, is built on a structure of systemic racism. So the same communities that have poor health outcomes pre-pandemic due to structural racism have even worse outcomes during the pandemic because of that very same system. For a small window into why, you can look at illnesses that provide further complications when someone gets the coronavirus, like diabetes or heart disease. Both of these things, which are very common in folks of color, Black and Brown folks in particular. When the prices of these medications go up, folks have the choice of either skipping or stopping taking the medications, or deciding not to eat or not to pay rent. Obviously, if you're treating someone with diabetes, obviously if treating them when they contract the coronavirus is bad, if they have diabetes, it's remarkably worse if their diabetes is poorly cared for in the first place. So this means price gouging has a direct impact on how the pandemic is sweeping through our streets. So finally, I just want to highlight the 5 recommendations that the report points to after documenting a lot of what I said, and even taking a deeper dive into Pfizer, AbbVie, Bausch, Eli Lilly, and Gilead, 5 of the worst actors we feel in the pharmaceutical industry. So our 5 recommendations to change the system are to ensure that medications and vaccines that are used to treat the coronavirus are offered free of charge. We know that medicine isn't a place for profit, and a pandemic certainly is not a place for price gouging. 2, the Department of Health and Human Services should designate systemic racism as a public health emergency and take concrete steps to address the racial disparities that happen in access to medication. 3, taking measurable steps towards strengthening the public's ownership of medicines and immediately starting to ramp up the production capability and reducing the process of simply extending medicine patents to these big corporations. 4, issuing reparations from pharmaceutical companies to those who were harmed by their past practices. And when we say reparations, we don't mean the $20 that you might get from a huge class action suit, but real, full, large payments that perform reparatory functions, as well as a direct acknowledgement and apology for the past harm. And finally, imposing compulsory licensing. We know that the government already has on its books the power to break up monopoly patents, and we really should leave no tool unused in stopping this horrible, horrible problem. So I'm very honored to be on the panel today with the rest of these great, smart folks, and I'll turn it back over to Tia.
Awesome, thank you so much, Mo. So now I'm gonna introduce our panelists and get into our discussion for today. So first I'm gonna introduce Victoria El-Hayek. Victoria is a coordinating committee member with Universities Allied for Essential Medicines. Next, we have Gina Owens, and Gina Owens is a 19-year community leader and board member with the Washington Community Action Network. And finally, we have Zain Rizvi. Zain is an expert on pharmaceutical innovation and is with the organization Public Citizen. Thank you all so much, and I want to ask you to get us kicked off. And our opening question is given just what Mo has shared, and we're talking about what is this kind of really critical crisis moment, but not just a crisis moment because of the COVID-19 pandemic, but really the different issues that have gotten us here. What is it that COVID-19 is revealing with challenges to getting access to treatment, access to good health care, access to even testing? What is this moment revealing to us about public health, about race, and about the role of Big Pharma and policy? now ask Mo to start us off, and then
Sure.
maybe kick it over to Victoria.
Sure. Yeah, no, I think that this moment, unfortunately is revealing that medicine in general, and certainly the pharmaceutical industry, is yet another place where capitalism and racism mixed together really just leads to chaotic and deadly impacts for communities of color. So, this is, as I said in some of the opening comments, before the coronavirus hit, Black and Brown communities were already suffering with access to healthcare and affordable medicines. When you add on top of that the fact that folks are in communities of color have lost their jobs, are facing eviction, everything else that goes along with the economic and health crisis that we're at the front end of here. You really just see this insidious system working together to make sure that Black and Brown folks are at the bottom. So I think we're learning a lot more about the ways in which that interacts. And unfortunately, we're learning that we need to create a lot more power in order for those things to change, because our current structures clearly aren't working. So, in particular, I remember the feeling when I heard Gilead announce that the price of remdesivir would be over $3,000. I mean, if you have a corporation that is going to price gouge in during a pandemic that's harming everyone, even you would guess some of their employees, family members, and friends, then really we're in need of systemic change, and that's something that we have to really build a lot more power for.
Yeah, Victoria.
Yeah, and just going off that, I think COVID in particular has just showed how messed up the research and development system we have right now is. Because currently the way it works is we award patents, which are a form of intellectual property, to corporations when they develop something that is useful and novel and whatnot. But when a corporation has a patent on a drug, no one else can use this product that's patented. So they have a monopoly basically. And in the US, there aren't really any price controls right now on drugs. So any corporation can charge whatever they want for whatever this new drug or treatment or diagnostic tool is. So we have seen this disproportionately affect communities of color over and over again. And this is something that has become an issue that's becoming more clear now. Like, as Mo had said, with Gilead and remdesivir and like CureVac and all these big companies who are working on treatments, who are selling them to the government already at these high prices. And the thing about this is, like, a lot of these discoveries are being funded with public dollars, so through our like tax-paying dollars, through the NIH. And with this, there should be a social contract surrounding these goods, so the public should be compensated in a way that is reflective of what they've already invested in this. But this doesn't typically happen, and this is something that isn't being seen to happen with COVID either.
Gina, I wanted to ask you to share a bit more about the advocacy work and how y'all what are you seeing as the impact in our communities around high drug prices?
Thank you for that question. I think in the communities, I would like to talk a little bit about the farms and the rural areas in Washington State. They actually do not have the full access to healthcare and the medications. And right now, there's a big push for undocumented and people who are working on those farms to get the care they need, to get the medication they need. But because there are so few hospitals and clinics in those areas, it's really kind of touch and go for them.
Yeah, and then Zain, your perspective, please.
I think COVID-19 is basically revealing in some way, what we've always known, just how broken the system is, just how horrifying the system is, and just how kind of racist the system is. One kind of analogy to think about here is hepatitis C. Hepatitis C is a disease that predominantly affects, marginalized communities, Black and brown populations, people who use drugs, etc. We, in 2014, got a cure for hepatitis C, like literally a cure for a disease that affects 5.2 million people in the US. And we're in 2020, and do you think everyone in the US who has hepatitis C has been cured? The answer is no, clearly not. And one big reason was that when the hepatitis C drugs first came online by a company called Gilead, which we've already talked about, they launched the drug at $1,000 a pill. So $84,000 for a treatment course. That was outrageous. Of course, like state insurance systems collapsed and couldn't handle providing the care. Of course, there were huge disparities in access, and of course, even after there's been some price reductions and there's been some progress, we're still at a horrifying state in which hepatitis C is still with us. It's crazy. Think about if we had come up with a cure for Alzheimer's or some other disease. Would we tolerate the fact that hundreds of thousands of people have not received the cure? And the answer is, of course not. Of course not. And so in the COVID context, we're seeing the same realities, sometimes with the same players, sometimes with the same corporations doing the exact same things. And so in the COVID context, a few of the panelists have touched on remdesivir. And to be clear, remdesivir is not like a miracle drug. It's a treatment. That can potentially be useful. It's been shown to reduce the amount of time it takes someone to get out of the hospital, time of recovery, which is modest, but it's important. If you're in hospital and you're struggling and you're suffering, and this drug can help you get out of the hospital like 3 to 4 days earlier, you presumably want the drug, right? And in addition to the price, which both Maurice and Victoria have talked about, one of the key concerns right now with remdesivir is actually supply. We're seeing huge shortages all around the country and all around the globe as well, actually. Despite the fact that HHS and Secretary Azar of Health and Human Services, said America first, and he tried to buy up all the supply. But the reality is that Gilead doesn't have enough supply right now. And so you're seeing shortages like reported in multiple states. And the reason we have these shortages is because, again, we award these corporations a monopoly. And so one corporation is a supplier for not just here, but for, potentially the entire world. And so the fact that we're not allowing, more producers, more suppliers, the fact that we're not taking this as a real emergency, as we're not taking, COVID-19 for what it is, means that a lot of people are going to go without access to remdesivir. And given what we know about the pandemic, a lot of those people are going to be Black and brown people.
Wow, thank you so much, Zain, for really laying that out. One of the things that I wanted to ask y'all to touch on and expound more is, we want to talk more about not just the impact, but about what are the underlying, not just underlying policies, but how is it that this is also racist? So in our current, kind of public discourse, we don't want to call things racist or name that they're racist, or we kind of say, we can't necessarily say that they are. But I think that both reading the report and seeing how things are playing out, we can definitely make the case that there are one of the underlying conditions that are resulting in the disparities, resulting in the lack of access that Gina talked about, is racism. And I would like for y'all to share a little bit more about exactly how this is impacting Black and brown communities in particular, and why that is, or why you feel that is.
Folks might know that my sister is, in addition to just being much smarter than me in general, she's an MD and a PhD, and so both a doctor at the Brigham in Boston and does research herself. And one thing that she often says to me, both when, you know, I'm asking her, like any sibling of a doctor, I'm asking her a bunch of medical questions about my health, or if she's just talking about her work in general. You know, the reason that Black folks are disproportionately impacted by, you know, X, Y, Z disease is not because there's some flaw in the genes or the DNA of Black people. So, you know, we often, people will think of diabetes as something that affects Black and brown folks, Black folks in particular, disproportionately, and that's true. But if you peel back the reason why that's true, you know, you get to all of the sordid pieces of American history that, you know, Black folks are in segregated neighborhoods that only have fast food options, no access to grocery stores, no outlets for exercise, et cetera, et cetera, et cetera. So once you start to peel these things back, you immediately see that, you know, the things that we can just sort of chalk up to, oh, well, yeah, and like maybe they're just different, like Black folks are just different, brown folks are just different. They're all based in, you know, our housing policy, our transportation policy, and all of these other things about American history that that we sometimes more readily can imagine how systemic racism has played a part in. So, you know, diseases and big pharma are no different. And you know, I think I might be probably among the more cynical people in the world, but I also see, you know, we've combed through lots of information about which drugs have prices raised and which don't. And I actually am not shocked by the fact that drugs that, you know, disproportionately impact folks of color get raised as much as they do. I think that there certainly is market analysis and risk analysis that's being done by these companies of how much of a stink are the public going to make if I raise the price on this drug. And in this country, that question has race baked into it. Like, who is going to care about folks with diabetes? There's all Black folks having to pay more. So yeah, I mean, I think that it's really front and center. And the other thing I'll add is, you know, we right now have, you know, someone mentioned Secretary Azar, and it's kind of like having like a fox guard the hen house with having Azar in charge, who was just an Eli Lilly executive. When you go to our report, you'll see all of these various racist and price gouging crimes that Eli Lilly is guilty of. And this is the person who's directing our, you know, response to COVID, our health and human services in general. It's really just maddening. And I saw someone put in the chat, dystopian. So yeah, I mean, I think that like everything, there's sort of a direct, you know, targeting and wealth extraction element to how pharma operates with regards to race.
I wanted to also remind participants that if you have questions for the panelists, you can use the Q&A function and we can field those questions a little bit later. Thank you for that, Mo. I wanted to ask both Victoria and Zain to talk a little bit more about the policies around patents and regulation that are preventing also affordable access to treatment.
I am assuming the silence means I can go first. So I think, why are medicines expensive, right? Like why is, you know, hepatitis C medicine costs $1,000? Is it because the medicine costs $1,000 to produce? No, not at all. We know that like manufacturers in India can, or you know, around the world can make these small pills for like pennies, literally pennies. The cost of manufacturing is negligible. It's never the cost of manufacturing. Medicines are expensive because pharmaceutical companies have what's called monopoly power. They have monopoly control. They have patents. They get awarded exclusivities. And what these exclusivities and monopolies allow the corporations to do is set whatever price they want. And inevitably, the price they set is just egregious, and it just keeps getting higher and higher and higher over time. And so how do they justify it? Well, they say, we know that the manufacturing cost is nothing, right? We know the manufacturing cost for many drugs is like, pennies, if not dollars. So why is a pill $1,000? The pharmaceutical industry claims that it's because of research and development. Like we're putting in so much money, blah, 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 and we need to be compensated. But that is largely a false narrative once you kind of peel back and see just how much the public, us taxpayers, are actually funding research and development and funding the advancement of medical science. And so the critical issue here is the monopoly itself, the patent, the exclusivity. And we actually have existing laws under the books right now. Like if Secretary Azar wanted, tomorrow, he could say, we're going to use these laws, one of which is called Section 1498, to basically break the monopoly, to allow other producers to come in, to allow market competition. And we see this all the time, right? Like in general, corporations are awarded a 20-year monopoly, and then there's generic competition. And when you see generic competition, you kind of, you've seen the kind of classic graphs, like the price goes down dramatically. And so if we break the monopoly, we can get more supply, more affordable supply, and lower prices. And we have these tools, and yet we choose not to use them. And so to kind of tie in the first part of the question to the second part, like, what would a drug pricing system look like that took Black and brown lives seriously, that valued Black and brown lives? And one of those things that system would do would be to actually employ the existing authorities, the things we can use right now to make a huge difference in people's lives. We would actually do it.
Yeah, I think Zain did a great job explaining the way the system works right now. And one thing that's also important to know is like a lot of these medications and treatment things that are being developed, like you said, are made with taxpayer dollars, so like do things like the NIH and whatnot. And a lot of them are developed at university labs, which have a social mission to help the public. And so once a lab or a company creates a new medication, they can then get a patent. And this patent gives them 20 years of market exclusivity and 5 years of data exclusivity for pharmaceuticals. So within that time span, it's pretty much just theirs. Like they have this monopoly on whatever this new pharmaceutical they developed is. And so there is something called margin rights, like which Zain touched upon, where the government can step in and, if necessary, take away pretty much just exclusivity for them for the 20-year period. But we have never seen them use margin rights at all. And it's part of the Bayh-Dole Act, where it gives universities the ability to sell off pharmaceuticals that they develop for this 20-year period. But this has been probably, I think 40 years ago, they made this margin rights law, and in the last 40 years, they haven't used it once. So this is now the time that we need to fight and urge all our representatives, our politicians, things like that, to start implementing this law that's already in place. The rules are already there for them to implement this, to get rid of this patent exclusivity. They just aren't doing it. So we have it in place. We just need to urge people to actually start implementing this.
And that, like the like, and the cost of them not doing it is so high. And I know, Gina, I know that I want to sort of coax you a little bit to tell a little bit about your story, because I think it's really, really powerful. And I hear a lot of stories that we might think of this as sort of like an insider baseball, let's get DC to do XYZ thing. But, as our report documents, and as I think several individuals who are in attendance right now can attest to, the costs are really, they're really, really personal. So Gina, I don't know if there's some outlines of that you want to share.
Yes, so thank you, Maurice. For me, there's two prongs to my story. About 20 years ago, I was in a car accident. It did some extensive damage to multiple areas of my spinal cord. So I was deemed disabled and no longer able to work. So that threw me into the cycle of, Social Security, Medicare, Medicaid. When I began feeling the crunch with what's called the donut hole, which was pretty much the prescription Part D program of Medicare, I started telling my story. I began meeting other people who were paying as much as 60% of their overall income for healthcare and medications. That is a huge amount. And they were actually at risk of losing their homes. That made me fight even harder for negotiating drug prices. In negotiating drug prices, I was learning a lot and also beginning to think about the other areas of healthcare. One in particular was my daughter's healthcare. She was a manager in a fast food restaurant. She fell ill in 2006. Her story is the one that was highlighted during the ACA when the little 11-year-old was talking across the nation about his mom, losing his mom to pulmonary hypertension. That was my daughter. Her story was really, really aggravating for me because there were flaws in the system that I feel like was a direct reason for her death. When she fell ill, she lost her job and her health care. Her health care was employer-based. And so we tried to go to the state and get her on Medicaid. But because she worked for a full year prior, she did not qualify. For me, I saw that as a flaw. I felt like there should have been a way for the state to say, in extenuating circumstances like this, when someone is really in need of healthcare and medications to live, we need to make those kind of provisions. They did not. Tiffany began getting sicker. Her pulmonary hypertension was causing her organs to shut down one by one, just because of water retention to her body. And because her organs began to shut down, she started throwing up as much as a cereal bowl full of blood. Her children were 6 and under. And of course, living with their mom, they were seeing this happen to her. How do you comfort a 6-year-old and younger who don't even know what they're looking at when they see those kind of things? You can't do it. But for her, it was more important for her to take care of her kids and make sure they had a roof over their head and food to eat than it was for her to have the medications that she would have had to pay out of pocket for. We ended up losing my daughter in 2007, and she was only 27 years old. What kind of nation do we live in? This is the richest nation in the world. We have enough money to do everything 3 times over. regardless of what it is. And our healthcare should be one of those things that we just don't allow people to take a second seat for. It didn't happen. And I lost my daughter. My fight now is to make sure that every aspect of healthcare is available to every human being. When I say every human being, I mean, I don't care what color you are, what race you are, what gender you are, what age you are. You should have the healthcare you need. I don't want to see another person live the kind of horrific things that me and my grandchildren had to watch and live through with my daughter. So I stay in this fight, even though I'm getting old. But yeah, I want to make sure that pharmaceutical companies are no longer being able to make a huge profit. I want to make sure that healthcare industries are, the insurance companies, I mean, are being held accountable and really step up to put more in the way of humanity in their work than profit. Because I gotta tell you, for me, there is no way I can look at any human being and say, your life is not worth a dollar bill. You know what I mean? And that's what our healthcare system has become, a dollar bill. Everything is about money, and we need to change that.
Thank you. Thank you so much, Gina. Really, I mean, it's just, I'm horrified by that story, and also just so deeply proud to fight alongside you. And yeah, I mean, thank you so much.
Yeah, Gina, I definitely want to say thank you. Thank you for sharing the story. I'm so sorry for your loss and for just the trauma it has caused your family. And I also want to just say that I'm very glad that you're getting old because we still have you here with us and we have you here to fight. So I appreciate the elders in the movement and the fact that you're fighting, you know, for your daughter's legacy, and so that other families don't have to experience that, and giving people power and giving people hope. And also, like you said, like, making this country stand up for what it is that we say we believe in people's humanity. And, you know, it's called the healthcare industry, but as we've heard from your story and from our fellow panelists today, you know, it's set up to advantage people making money and making a profit at the expense of our lives, at the expense of our health. And it is not right. And I'm so moved because this is not just about the numbers and the policies, but this is about what's happening to families like yours and what's happening with families like yours. And also how what you shared is also connecting, for me, really understanding even more about when we talk about the housing crisis and how affordable housing is, how affordable healthcare is, and the ability for people to, you know, work hard and take care of their families and have their, you know, just have their lives. It really is just really painting the picture and really solidifying for me how all of these issues are connected. We're not just talking about the healthcare industry, we're talking about how our communities are being targeted and extracted from. And it's being enacted through these policies. And as Victoria and Zain talked a little bit about, we actually do have some laws and policies in place that are not being used in order to protect our communities from the situations like what you've experienced, Gina. And I just want to say thank you so much for even just being able to share that story, as well as being a really freedom fighter and bringing the fire to our lawmakers about these things. So just thank you so much.
Thank you for allowing me to do it.
Always, always welcome.
I just want to highlight another thing from the report that I just dropped in the chat, but I just want to say it out loud, sort of in contrast to what we just heard. So we profile 5 different companies in the report, and they're 5 of the largest pharmaceutical companies. And just in 2019 alone, they made $139 billion with a B dollars. Their executives alone made $277 million in salary. The amount of money for the medications that Gina was talking about is literally, it's less than a rounding error for them, either in their salary or their profits. It literally would not show up on an audit if it went missing. That's how little money it is compared to the obscene profits that they're making. So, we really need to build the power that can dismantle the system that clearly has no moral compass to allow something like what happened to Gina's family to happen, while pharmaceutical executives get to buy another house or buy another yacht or do whatever they do with their $277 million.
Yeah, on that point, I just, thanks so much, Gina, for sharing that story. It's just so powerful and so heartbreaking, so heartbreaking. It's a cruel system. And one of the saddest parts about it is that it's a story that is so common in this country. There was polling done a few months ago that asked Americans, about medicine access and their kind of issues struggling to afford healthcare. And in that poll, 34 million Americans said that they knew someone who died from not being able to afford treatment. That is insane. 34 million, as Gina said, in the richest country in the world, the richest country in the history of civilization, has 34 million of its own citizens dying or knowing someone who's died because they can't afford treatment. And what is particularly striking about those stats, if the 34 million isn't just egregious enough, that it's 13% of Americans know someone, but if you break it down by race, 20% of Black and brown people know someone who has died because of not being able to afford treatment, compared to 10% of white people. So Black and brown people are twice as more likely to know someone who has died from rationing treatment than anyone else. It's inexcusable.
Yes, thank you so much for that, Zain. One of the questions that has come in is also asking about, the recourse that folks might have, or do we have, when it comes to things like product liability or medical malpractice. So there's a comment in the chat also about diabetes patients being denied treatment, are not able to access affordable treatment, and then having to have amputations done, which is, preventable in a lot of different cases. And so asking about, are there other things that are contributing to the high cost of drugs as well in the medical system, and is tort reform a part of advocacy work? Is that an option, or is that something that we should be thinking about?
For me, the answer is it's greed. The reason prescription drug prices are high is because of greed. There are kind of rationalizations to that greed that the industry will put out, and whatever that rationalization is, sometimes it's R&D, sometimes it's something else. There's really nothing stands up to the weight of evidence. There's nothing. If you actually analyze the data, if you actually look at kind of where the money is going and how much profits they're making, the simplest answer, and I think the clearest answer is to go after the monopoly pricing power of these corporations. There's no reason why Medicare, for example, which is literally the world's largest purchaser of prescription drugs, the world's largest purchaser, like Medicare buys $100 billion of drugs a year. Medicare does not negotiate in this country. Imagine spending $100 billion and not negotiating for the price of what you're buying. Like, it's just, it defies belief until you understand that the biggest challenge here is the power of the pharmaceutical industry and the way that it has kind of influenced our thinking, our politicians, our kind of understanding of how drug development works.
Thank you. Mo, you wanted to share?
Yeah, I mean, I just want to add, like, it's a really interesting question, because I think it points to a tool that Big Pharma and really other corporations use often, which is to just distract from their greed by throwing other things that they could point to as the reason that the medications are so high. So like that your doctor's visits are high because of medical malpractice, or instead of the fact that when you get your bill back, you see that pharma has charged so much for the medications itself, or the classic one with Big Pharma is innovation that we talked about earlier. That, like, well, of course our medications are so expensive because we're innovating. We're coming up with these new drugs. Who else could do that? So of course that's why we have to charge so much for medications. But when you see, as Victoria was saying, that like these medications are, for the most part, the research is done with public money, and add on top of that so many new drugs that come to market these days are what are called Me Too medications, which are essentially, one tiny thing has changed, if it's changed at all really, but one tiny piece has changed to treat something that we already have a reasonable treatment for, just because there's profitability in the market. Those are the kind of drugs that they're bringing to market. That's not the kind of innovation that we want. So why are we paying so much money for that? So I think what both Zain and Victoria earlier were driving towards. I think we need to stay focused on really breaking up pharma's monopoly power and calling them out for their price gouging, their insatiable greed, and their racism, and how it directly is leading to the death of lots of people who really should still be here.
Yes. With our last few minutes, I wanted to ask each of you to share, what is it that you're doing and what is it that we all need to do in order to fight this fight, like Mo is talking about, just in our last few minutes. What do we need to do? Who do we need to talk to? And what is it that we need to understand coming away from this conversation as we move forward today?
I'll go ahead and go.
Yeah, I started all the other times. You go, Victoria.
So I am currently working with Universities Allied for Essential Medicines, as Tia said earlier. And a lot of the work we do focuses at the university level of research, because a lot of the things that are coming out, a lot of the research that's being developed and things like that start at the university, at research labs there. Especially here in America, almost every university has a ton of research labs, and most of them are focused on COVID right now. So urging these universities to develop policies, especially their technology transfer offices, and then the researchers themselves to promise to basically have an open license for anything they develop towards COVID, and why that's important for these communities who are always disproportionately advantaged when it comes to just pharmaceutical pricing in general. So urging just universities to stand up to the social mission of helping people in need and trying to change their policies to gear more towards open licensing versus this exclusive licensing that leads to these monopolies.
So I think that with advocacy, it's important for people to understand two things. One is that our lawmakers and our policy writers will tell you that, you know, being experts, they know best what should go into those policies. I'm sorry, I beg to differ. The people who actually live the policies that have been created for us are the real experts. People like me, people like my daughter, people like all of you. And for me, you'll never hear me talk about statistics. You'll never hear me talk about facts and figures. And the reason being, there's so much of that already out there. There are so many reports. There are so many roundtables, not like this one. This one is a good one because we're all fighting, right? But there are so many higher up that sit at a round table and shuffle papers and talk about how much they're doing to further the cause, when all they've actually done was push the paper to the next person to them. What needs to happen is that every single person who has lived a healthcare story needs to get up off their seat and talk about it. Because if you don't talk about it, my mom used to tell me, my foster mom is from the South. And she was a firm believer in, if you do not open your mouth, you do not get fed, right? If I don't open my mouth and tell my story, nobody knows about my daughter. Nobody knows about how she lost her life. If the people who are living these horrendous stories don't talk about it, those policymakers don't hear it. Those lawmakers don't hear it. And that's what needs to happen. We need to flood every office, every lawmaker's district, and all of that with personal stories, because those are the real, like I said in the beginning, they are the real experts. That's what needs to happen.
That's amazing. I think from my end, I have two thoughts. One is that it's just so critically important for people to know and understand that the government already has so much existing authority to lower drug prices, to make medicines affordable, and to increase access. And the fact that we're not using that authority is a massive failure, you know, like an absolute failure of policy making. And so I think it's incredibly important for people to kind of push, you know, wherever they are, but to push policymakers to understand that the government is funding so much of this research. It has, you know, enormous existing authority, and it can make a difference right now if it wanted to. So that's one part. The second part, I think, which, you know, I would regret not mentioning at all, but I think it's critical to mention, is that we focus a lot on the domestic aspect here, which is, you know, crucial. But there are going to be, you know, if we get a COVID-19 treatment or vaccine that works, there are going to be 7 billion people in the world who may need it. And so this fight, you know, is combined with the global fight. And we need to work in a way that recognizes that it's not enough, you know, if, you know, 300 million people in rich countries get access and really like 6 billion brown and black people all over the world don't. And so we need to work together with, you know, our global allies and force policymakers to take on pharmaceutical corporations and to deliver what we need as a global society, and not just think about, you know, their narrow national self-interest.
Everything that folks said, and highlight the 5 recommendations that we have in our report. But want to double down on, you know, we released several reports at ACRE, and one of the things that I always remind folks when I'm talking about the recommendations from our report is that, none of this is going to be possible without building power and truly demanding these changes. So I hope that everyone who's attending the call goes to the ACRE website and reads through the report and shares it with the folks in your network and share it with your legislator as well. But I think that we can not mistake doing this research and sharing the report with the actual political power and organizing power that it's going to take to make some of these changes. I could give this report to every single congressman and senator on Capitol Hill, and I could sit down with each of them and force them to read it line by line by line, and it still wouldn't be enough, right? They're not going to respond to letters on a page. They respond to people in the street and to powerful stories. So that's sort of my one thing that I want to leave folks with is that, for the folks that were victims of this system, like Tiffany, and the folks who are still fighting, it's all of our duties to get together and build the power to make sure that the system changes.
Yes, 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 building power. Thank you so much to our panelists, Gina Owens, Zain Rizvi, Victoria El-Hayek, and Maurice BP Weeks. Make sure again to visit ACRE's website to download the report and to share it. And also to continue the fight, as all of our panelists have shared, we know that one by one, all together, we can continue to turn the tide and to create, right, the structures and the systems that we are believing in, as well as to hold these racist institutions accountable in order to begin to repair harm has been caused on our communities. I want to say thank you so much to everyone for your time today and for joining us and for sharing your knowledge and your expertise on this fantastic roundtable, and wish you all, a fantastic Tuesday and good health and continued success as we continue in this fight together. Thank you.
Thanks, everyone.
Thank you, Tia, for being such a fantastic facilitator.
Here, here.
Gina, thank you. I appreciate it.
Maurice, thank you so much. Victoria, Zain, thank you all.
Thank you.
Thank you.
Bye, all.